My task now for the next half hour or so, I'll be talking about Huntington disease around the world. When we thought of this conference, last time I talked about the history of Huntington's over time, and I just set myself a task, and I think it was a bit too ambitious, to talk about what is happening in other areas around the world, so in terms of the space dimension, if you like, rather than time. So what I plan to do is to talk about some epidemiological concepts, some terms that we commonly use when we talk about frequency of diseases or prevalence or incidence, HD in different countries. And by this I mean not just the figures, how common HD is, but it's also the services and attitudes, how people perceive genetic testing, how people think of prenatal testing, and services. What do people want? And what do they think is lacking? So it will be just some highlights and some lessons from around the world, some messages that we probably ought to think about. To do this, I thought I'll do a bit of research, review, literature review. I've done quite a bit of this. I did write to people personally from around the world. I had some communication with the International Huntington Disease Association and our, obviously, local Huntington Association within the UK as well. And I had a look at a number of websites, relevant websites, to know what exactly is happening around the world, just to have a view. Are we doing reasonably okay in this country? Should things be better? Should we improve on things? So what I mean by epidemiological concepts is questions like, how common is it, HD? Is it increasing or decreasing? And why? Why is it so common somewhere? There are some hotspots, as I will talk about, around the world, and others, it's hardly there, like in Japan. And how much greater is the heterozygote frequency? What I mean by this is people are carrying the gene, whether they are asymptomatic or pre-manifest, representing birth incidents. How greater is it compared to the prevalence? The prevalence is like the number of patients compared to the population at a specified point of time. What geographical variations are there, and how can this be accounted for? Does the normal CAG range, because as we know, we all have this. We have a CAG range in our DNA. So, but this range, that is classed as normal, there is still a wide range of that normal CAG. Does it make any difference if the range is at the higher part of that range, so it's towards just approaching the abnormal range, but it's not abnormal yet, compared to a different population that is in the lower range, we still class in just one normal range. But does it make any difference in terms of developments of Huntington's or future development of Huntington's? Why is it important? When we think about those issues, we will need to think, obviously, the bottom line is patients. What can we do different to patients? So how can we plan services? And how can we plan research? How can we allocate funds for research? How can we interpret certain preventative measures? And how can we study small population to understand the attitudes and whether we should develop the availability of genetic testing a bit more, or should we go the other way because it's not taken on very frequently around the world? So those questions, unless we have some figures, we wouldn't be able to answer them. And health services, research funding bodies, they need to know about this. And as we will talk about at some point during my talk, the prevalence of HD in the UK is thought to be very much underestimated. So maybe we have at least double the number of patients that we thought we have probably prior to 2010 paper that we'll talk about. The trouble with epidemiology is it started with infectious disease. It will help us that certain organism will cause certain disease. And when we know that patients have a certain place where there's a certain sort of concentration of population who suffer from this disease, it will help us understand the etiology or the causation of a disease. And the same with chronic neurological condition that with complex etiology like MS or motor neuron disease. But with HD, the situation is rather different. We have a gene. So it isn't just we need to survey the population, we need to focus on families, and people who are at risk are mainly family members rather than the population at large. At least 2 studies indicated that if we take the genetic testing into account, the prevalence that we know or we knew before 1993 is probably will become much higher. So the frequency of HD will become much higher. Specific groups will illustrate this, such as elderly patients with no family history, and they have a bit of jerks, but people say probably it's old age, probably it's drug related, and those people may pass away and never been diagnosed. The trouble is, if we don't diagnose them, we don't diagnose any secondary cases either, so we don't diagnose any of their family members. So it's quite important to take this into account, molecular diagnosis, not just the epidemiology. That is the genetic testing we need to think about as well. Heterozygote frequency, what I mean by this is people who carry the gene. So heterozygote is when you have one abnormal gene and one normal gene. Because that is, HD is an autosomal dominant, heterozygote frequency will be roughly 2.5 times the prevalence estimate. So if you have 100 patients, you have 150 pre-manifest gene carrier. So you have like a total of 250, that is 2.5 times the number of patients. And obviously the gene frequency in the community will be, or in the society will be half of that, because we have only usually 1 copy of the gene. It's very uncommon to have the 2 copies, except in very specific populations, as in Venezuela, and we may talk about that as well. So the number of at-risk individuals, including only first-degree relatives, will be around 5 times the number of affected individuals. Again, we need to think about those things, because actually what we're living in, the situation we're facing now is people are having the genetic test, and they walk away with a genetic test result with no services available. So because it only became available in 1993, although obviously the gene was located in 1983. Apart from family surveys, and what I mean by family surveys is just focusing on family. It's like detective work to some degree. You go and try to examine that family, go and visit them at home, and try to identify secondary cases, and try to have a set criteria right from the outset. We need to investigate, to carry out an investigation, say for 3 to 5 years. We do that, and we need to have a prevalence date about 5 years or even 10 years, where patients can be identified, but it isn't that they already passed away and forgotten about. We need to specify a certain locality, probably a political or administrative locality that we need to examine. So this is what I mean by family survey. And we have Dr. Quarrel with us today, and he has done quite a bit of work in that area as well. But there are other ways of investigating this, maybe less. I think it's complementary. So we need to use different ways of identifying cases. So it isn't just about asking questions or taking history. Other ways will be examining correspondence to GPs or neurologists, or death certificate is what I'm going to talk about now as well. Examining death certificates it's not a straightforward thing, because it is really good because you have a very sort of standardized way of assessing things. So you know exactly what is on the certificate, and there are some statutory requirements as to how you complete the certificate around the country or throughout the country. So it's a good thing in a way. It's very standardized and very uniform. Trouble is, sometimes GPs or whoever doing the death certificate may not be that keen to put Huntington disease as a diagnosis. Maybe they're trying to protect the family. Maybe they think this is just a subsidiary diagnosis, not the main diagnosis. There are some issues with ICD classification and how things change over time. If HD isn't identified as a main diagnosis, you tend to just go for something else, movement disorder. But death certificate can certainly help in understanding trends over time. and having longitudinal studies, what happened over time, because you have this and you don't even need to collect data, it's there. Other ways would be just examining neurological conditions in the community and how many people will have, or neurodisability rather, how many patients will have MS, motor neuron disease, or Huntington disease. This is another way. To be more sure that we are actually addressing all cases in a society, we need to try all those. And the more methods we try out, the more certain, or probably potentially certain, that we are not missing out many cases because we have tried different ways. Now, just some highlights or some figures from around the world. Britain. We know that Britain is probably one of the most studied places around the country, around the world. And we know that any other, it's not even just the country, we have figures from specific regions, specific districts sometimes. And it's very assuring that we're now even have a genetic register that will help us understand what is happening and what has been happening over the years. There is no clear pattern to suggest that there is a single focus of the disease. So you have a prevalence rate in Wales similar to East North Scotland. So it's very difficult to think that probably they're coming from the same family. Recent studies, and I'm sure most of us will have heard of Sir Michael Rowland's paper in 2010 in The Lancet, and he is indicating that actually probably the prevalence of HD in this country is well underestimated. The argument he's putting through, obviously there are only assumptions that we can make. Why? Why do we think that? Previous studies relied heavily on data from the Huntington Disease Association. Some patients, as you will know, that wouldn't be keen to get involved with the association at all. Further, the association wouldn't cover all the districts, all the areas around the country. This paper triggered a number of responses from Belfast, from Australia, and what people came up with is other assumptions as well. Now people probably live longer, so we have more people in their 50s and 60s, and you can make a plausible assumption that probably we have more HD patients. Also, we have a better health care, so people will live longer, and in that case, then you would expect us to have more HD patients. The availability of the test only in 1993, then again, this will make us wonder whether we have more patients because now people are tested and we can diagnose this. In the past, I don't think it's an uncommon scenario when you see patients and they will say, I don't have any family history as such, but my granddad died in a nursing home with Alzheimer's disease. And when you take more history, probably it was Huntington disease. We have less complete data from Ireland. Britain is the origin of HD in certain countries, Australia, USA, Canada, South Africa. History of erroneous interpretation, and we talked about this last time. I appreciate that most of you may not have been here, but just in relation to history and how our patients suffered throughout history, and that's why, again, the stigma of HD would be probably contributing to why the prevalence in this country may be underestimated. Because people thought that there is an association with witchcraft, with criminality, and patients moved from, or the ancestors of some patients moved from East Anglia to New England in the States, and probably they are, even at some point they were blaming this country because we exported those patients, and very nasty comments came out in even public press and scientific press in the old days. It has not been possible to prove common descent between the distant HD population and living HD patients in this country. I talked about keeping medically genetic register will help us, will lead to total ascertainment, that is knowing exactly that this is the prevalence and that's it, we're not missing many patients. Will help us keeping complete regional prevalence data and help us monitor any trends resulting from genetic counseling and predictive testing. We need to know what's happening with the prevalence following this. Are people less inclined to have children? We don't know. And unless we understand the attitudes and keeping that register, I think it will be a struggle. In Germany, we have lower estimates in some surveys. In the first half of the 20th century, figures were lower than expected. But it became even much lower after the war. And the reason, or the assumption, is reluctance of families to cooperate on account of historical experience, the Nazis' policies of compulsory sterilization and some strict regulations in marriage, and even killing patients with HD. And those eugenic views makes people wonder, should we go for the test or not? Still, this is an issue when we talk to people from Germany. The uptake of pre-symptomatic testing in Germany appears to be considerably less than neighboring countries, one study shows. Although it is lower anyway around the world, but still it's lower in Germany. There is a German origin for many families in North America and Australia. It's not just Britain. Other European countries, HD was thought to be more predominant in Northern Europe, but now we know that it's not less common in Greece and Italy. Again, people talked about low prevalence in Finland, which could have been comparable to Japan, but subsequent studies actually indicating that it's probably approaching the expected prevalence for Europe. In USA, considerable understudied compared to Europe, and the problem of population mobility. People will migrate a lot, either into the country or within the country, which will make keeping a genetic register less valuable. Tracing the origin of the families outside USA, again, over half of the kindreds could not be traced outside the USA. So they're actually probably from the USA, or at least a good percentage of them. And those who could be traced came equally from Britain, Germany, and other European countries. The overall prevalence is around 5 per 100,000. And you may know of the US Huntington's roster. You keep a register of people with Huntington disease, but it isn't for prevalence purposes, but it's quite valuable in terms of studies, because you could obviously recruit or use it for recruitment. In Canada, French Canadians, they will have a very concentrated group. They have high prevalence of genetic diseases, but not Huntington's in particular. They're mainly of English origin in Canada, patients with Huntington's disease. Tracing families to an origin outside Canada, again, a number of countries, mainly Britain and Ireland, but less so from USA, Germany, and France. British Columbia is an interesting place. When it was studied in 1983, the percentage or the prevalence was higher than expected. And then this prompted people, and again, this is the idea of having some of those dry figures, and why do we need to know that? Then they started to establish a better service, not just for care, it's also for research, for genetic testing, and from British Columbia, they tried to have equitable access throughout the country to this particular place. So subsequent studies in 2001 show that approximately 24% of patients wouldn't have been identified if it wasn't for genetic testing, because they didn't have family history and the history is vague. And again, it's quite important to bear that in mind. You know about the Venezuela project? About 100 patients, probably thousands of patients in a pedigree, and you see those fantastic pictures where you have a pedigree family tree hung up on a number of walls to be able to follow things. And it's a very useful population to study. Not just the attitudes, it's also, it helped us to identify the gene eventually. But the medical care, the fact that because of the stigma, because of extreme poverty and lack of medical care, they tend to, there's no much of intermarriage between them and the other populations. So they get married to each other, basically. And then a group of patients will come up, that patients who will have two parents who will have Huntington. Some of the patients will have homozygote. They will be classed as homozygote, so you have two copies of the gene. So far, there is no clinical implications because the clinical presentation shouldn't be that different, but I think it's quite useful to study this group. Interestingly, in a simple population like those small villages around Maracaibo Lake in Venezuela, it's a very isolated group, very isolated place. And actually, it became more easy to accept the disease, paradoxically. And again, if we want to think about how we can address stigma, sometimes just knowing the frequency and knowing that this can happen to, I mean, this is distributed around the world, it's a genetic disease, and changing attitude towards genetic testing can be quite helpful. But just in a simple population, the acceptance may be easier. And this is what was demonstrated in this project. And obviously, you heard about Nancy Wexler's work in there. In Asia, we don't have much data, but doesn't mean that we don't have Huntington disease, but just the studies are not available. Some studies in the immigrants in this country showed that the figures were just under 2, 1.75 per 100,000. But it's actually, if you take into account that how many of people with Huntington disease will be immigrating to this country, and the restrictions for immigration, etc., probably they are approaching the European levels as well, or levels, the average world level, if you like. General figures suggest a possible prevalence similar to Europe. HD in Chinese populations have mainly studied outside China, and we hear 2011 there was the launch of the Chinese HD network. We have a number of case reports from different countries, but as I say, they're far from full ascertainment or total ascertainment. So we don't have the whole data, but there's some work that has been done. Why is Japan having such a low prevalence? It's just an interesting question. And we don't think it is because of methodological errors. We don't think it's because people didn't look for patients good enough. I think what has happened is actually it's true figure. People in Japan will have less frequent Huntington disease because they identified higher frequency of other genetic disorders. They have very well-developed neurological services and neuropathological research networks, so they would have picked it up. Why is this happening? We may touch on it, but it may be related to, again, that lower range of CAG, normal CAG repeat in Japan. One assumption is the higher range of CAG repeat. Over time, the CAG repeat may become unstable, and then people will enter the affected range. So we don't have to sweat too much just to find who is the ancestor of this particular group, who is the patient. There may not be one. There may be just things that have developed over time. In Australia, we have active HD research, not just in terms of epidemiology or prevalence, in general. And you know that the last World Congress was in Australia on Huntington disease. A number of prevalence studies available from different states. The origins and spread of HD in Australia is similar to what took place in America about a century ago. So people have immigrated to Australia, and especially, again, from Britain and Germany, but no association with criminality. Reassuring, yeah. I mean, criminality wasn't blamed, or nobody said, actually, there are some criminals here because of that. Actually, interestingly, in history, when you read about this, people made the diagnosis based on criminality. So they said this person was involved in lots of witchcrafting and criminal behavior. Probably they had Huntington's. So it was quite unsettling. The island of Tasmania, and it is thought that the origin of this group would be from Somerset in England. Subsequent studies in Somerset show that there are certain clinical criteria that is in common with patients in Tasmania. So they have like late age of onset and late death, age of death, and it was similar to what is happening in Tasmania compared to Somerset. Pacific Islands, the assumption is the people from the whaling industry, mainly the New Englanders, who had relationships with sorry, am I in the way? With people from the island, probably introduced the gene. And there were some evidence based on surnames, for example, from the Davenport report and Muncie's report, that people shared the same surname. So probably this is how the gene was introduced. In Africa, considerable difference between major ethnic groups, more common in white and mixed race compared to the black population, but this is again has been disputed. European origin. Mauritius, the importance of microepidemiology. Again, you have a very small population, and the prevalence can be as high as 48 per 100,000, which is obviously huge. And understanding this population it gives us a model of how we can, because what happens in huge countries, people get forgotten about, and it's not a priority in anybody's agenda. But if you can make a case based on findings from small populations, then you may convince relevant authorities. Other African countries and American blacks, isolated reports from different countries, more recent reports from Togo and Zimbabwe. Possible conclusions include that HD is less common in African countries in general, but it is just a possibility. Whether this is related to methodology and is to remain to be seen. Other African countries and American blacks, again, the frequency of HD in American blacks thought to be 1/3. That is the white population. But interestingly, it was based on 3 cases. So if you have 5 more patients, then we would have said it's the same. So people make those assumptions based on small numbers, and that's why it's useful to read the full study rather than just pick up a conclusion and take it at face value. Equal prevalence in black and white population. Subsequent studies showed that. Similar values by other researchers as well, based on death rate. Earlier onset in blacks, some clinical differences, quite interesting I found. So patients with HD, if you're black, you may have less bradykinesia. You'll have more bradykinesia. You'll have more frequent involvement of eye movements and less severe mental health problems. Paternal transmission is similar in all races. Origin of HD in American black population, initially it was thought, again, it's probably they mixed up with the white population and this is how they got the gene, but now there are a good number of families and you can't trace it outside the black population. We talked about the importance of studying migration. Early American studies and more recent ones will show different figures based on that, and making assumptions and having this sort of oversimplification that it's just a family immigrated from this place to that place probably wouldn't stand now. Probably what happened in America, yes, it's related to immigration, but it's from Europe rather than just from East Anglia or from a specific place around the world. I will try to go a bit quicker. This is the hotspots I told you about. Prevalences are much more than expected in these particular groups. The normal CAG range, I think I talked about this quite a bit already. And even that pattern is recognized in other disorders, not just HD. The relationship between the normal range of CAG repeat or whatever repeat related to the disorder compared to the prevalence. At a local level, probably what happened locally is what matters. There may be a large kindred or a population movement, but within larger population, there's a consistency usually within ethnic groups. Variation in the normal distribution of CAG repeat length, as I said, is more likely to affect only differences in the major group, but you can't say it's this group probably this would be of any weight, because it wouldn't. Effect of genetic testing in HD prevalence, mutation analysis, we said it would lead to more identification of more patients, And the use of molecular techniques is not likely to have major short-term effect simply because most people don't go for the test anyway. So it's maybe 20 or 15, as you could see, patients will, and even not patients, sorry, at-risk individuals will go for the test, and even it may be much lower usage of prenatal diagnosis testing. Just a few messages from around the world in relation to attitudes and services. Some countries, this is just a very generic and expected statement, really, but it is evidence-based. So some countries, they may not have heard the word Huntington's, and I'm talking about doctors, and just they read about it in medical school. But in terms of services, because of limited resources, they may not have much in this respect. People from UK and USA, they do acknowledge that professionals don't know much about HD, and this is not a criticism, it's just a very uncommon disorder. They look after a huge amount of other disorders, and they don't know much about this. So a study showed that if you have a group of interested individuals, they can be quite influential. And this is hopefully one of the objectives of this kind of events like today. In the Netherlands, we have the care chains. I read about this, it's quite interesting. You have like 3 nursing homes attached to each other. They complement what they do. And it will cover a number of settings. It's not just, when we say nursing home, what comes to mind is residential settings, but it's not just that. We have also Huntington Center where there'll be support for carers, for researchers, for clinicians, for people who are at risk. And they will have day centers, they will have short stay periods, outpatients, and even addressing criminal behavior. Patients in Australia, professionals and patients highlighted the strong need for both basic services and specialist services. Reports from New South Wales in Australia again highlighted the need for a better nursing care, because what happens when people looked after in an old age or elderly home, nurses will be less satisfied with the setting, patients will receive less good care. Outreach HD team in New South Wales, input ranges from outreach clubs, lots of things, but what I found quite interesting is even after the departure of the person, this is not the end of it, because there will be a bereavement for the family, and also the other family members and children who will need to be looked after. We can't just simply close a file if this person, our client, has passed away. In Italy, there's a home healthcare experience, home assistance at home at a cheaper price. But what I found interesting is they don't shy away from using the word inpatient rehabilitation, which we tend to say, oh, rehabilitation is for curable conditions, for people who will get better. But actually, they can still admit patients for a certain period of time and address a certain need. So mobility, swallowing, and we can get them better in that by making certain recommendations or giving patients certain treatments. In a way, concerns over continuous, again, this is another cultural thing. We don't think much about this in this country, but in other countries, it's something that will be coming up. The impact of HD on carriers, sufferers, and families, because they're excluded from basic health plan. Again, it's another country, but we need to think about it. There is no satisfactory data regarding the care of HD patients and the carers in Latin America, but recently there is the Latin American HD network. North India, again, there are some limited resources. The impact of psychosocial interventions was studied, and positive outcome was demonstrated. So it isn't just about medications, it's about working in a team. I'll finish off by just highlighting a couple of messages from this interesting survey. I'm sure it will be available everywhere online, and I did have a personal communication with the International Huntington Disease Association. And what they did, they sent an email via email, 15 questionnaire. They asked these kind of questions about what they do in the associations and the care they provide, involvement in research, financial constraints, etc. Whether they have any literature, whether they have support from pharmaceutical industry. And what came out was just a couple of messages. Results of that survey correspond, as I say, 30 associations from 26 countries, a number of interesting and innovative services. We hear about camping and theater performance, and patients things that we don't really think about because we think of antidepressants. But I think it's quality of life. It's much broader than elimination of symptoms. And research, how an association will support research, it isn't just about grants, it's also involving researchers in membership, it's fundraising, it's awarding researchers. Interestingly, the greatest need for the different branches was financial, expectedly, isn't it? But what is interesting is if you are an association for Huntington disease, have been around for a while, then you probably have will be doing more to patients, but you'll have more needs. So you'll be having more activities and supporting individuals probably a bit better than people who have been around only for a short period. But you'll have more needs and more financial needs than anyone else. I think I'm nearly there, so this is just a summary. So what I tried to cover is just to talk about why epidemiology is important, and I did present some highlights from different countries in terms of services and attitudes, and then I finished off by the survey from the International Huntington Disease Association. Thank you very much.